So tonight's session is continuation of chamber quantification, looking at aortic annulus and the aortic root. This is one of the most important areas that you're going to do. When you do your echo, looking at the aortic annulus and the aortic root is extremely crucial and important. And the reason why it is even more important today is because of the procedures that we're doing. We do transcatheter aortic valve implantation, the so-called TAVI, and the transcatheter aortic valve replacement, so-called TAVR. Those procedures requires us to have a very close look at the aortic root and the aortic annulus and do accurate assessment on them. So we're going to spend a little time. So by definition, the aortic root extends from the basal attachment of the aortic valve leaflets within the LV outflow tract to their distal attachment at the tubular portion of the aorta. And I explain on the diagram what that is. But you're starting from the lowermost attachment, and you're going to go distal in the tubular portion of the aorta. So when we say evaluate the aortic root, we want you to evaluate all of that. So the aortic root is a geometrically complex structure that includes the aortic valve annulus, the interleaflet triangles, the semilunar aortic leaflets and their attachment. Now, the aortic sinuses of Valsalva, that's the outpouching of the aorta. And you should also measure that. And then the sinotubular junction. So you want to do at least 4 measurements when you're evaluating the aortic root. The aortic measurement should be made at the following sites. The aortic valve annulus, so you're going to measure the annulus. You want to measure the maximal diameter of the sinuses of Valsalva. You want to also measure the sinotubular junction, and that is where the sinus and the tubular portion sort of meets. And then you're going to look at the maximal diameter of the proximal ascending aorta. So those are the measures. You want to get all those measurements. And it's very important. So you'll do, I know a lot of you looking at this and say, isn't this the diameter, the LVOT diameter? No, this is not the LVOT diameter. And we'll explain why. But you want to measure the sinus of Valsalva, so from sinus to sinus, you want to get the width of that. This is the sinotubular junction, where the sinus meets the tubular portion, and then you want to measure some portion of the ascending aorta, the widest diameter of the ascending aorta. Now, again, the sites for measurement of the aortic root and the ascending aorta. This diagram illustrates 4 sites at which measurements are recommended. The aortic valve annulus. So when we talk about the aortic valve annulus, if you were to look, or if you open the aorta, you're going to get, the cusp. So this is the right coronary cusp, the non-coronary cusp, and the left coronary cusp. The lowermost portion of these cusps, if you look at it in its natural geometry, the lowermost portion, if you join this lowermost portion and you make a circle around it, this is what we call the annulus. Okay, so So this is the annulus. And if you measure, so when we measure one supposed to be measuring the diameter of this area. Okay. So the aortic valve annulus, which is the inch point of aortic leaflets, the sinuses of, so we're talking about the areas you're going to measure now. So you're going to measure, this is the valve annulus, and then the sinus of valsalva to the sinus of valsalva, that's the maximal diameter, usually at the midpoint in the sinus. And the sinotubular junction. Okay, so this is your sinotubular junction. It is the junction between the sinus and the tubular portion of the aorta. And then the proximal ascending aorta. That's the distance between the measurement site and the annular plane. Okay, so you want to do at least 4 measure of the aortic root. The aortic annulus should be measured at peak systole. So this annulus, or the annular measurement, should be measured at peak systole, and then all the other dimensions should be measured at end diastole. So your sinotubular, sorry, your sinus to sinus, sinotubular, and the ascending aorta, those are measured end diastole. Okay. So when we talk about the aortic plane, this line that sort of runs parallel to the wall of the aorta. So that is your aortic plane, and so your measurements should be perpendicular to this plane. You can see that this aortic plane is different from the plane of the LV. Okay, so the dashed line depicting the longitudinal axis of the left ventricle, that this dashed line, and that of the aortic root and proximal ascending are different. So you can see that this aortic plane is different from the LV plane. Okay, so it's important to understand that when we talk about the annulus, this is what we're talking about. All right. So what are the different measurements? So there we have the measurements for males and females. So the annulus in men is about 2.6 plus or minus 0.3, and females 2.3 plus or minus 0.2. And you can also get the index value as well. And then you have the measure for the sinus of valsalva. So remember, the sinus of valsalva is a little wider than the rest of the aorta. So for males, 3.4 plus or minus 0.3, females 3 plus or minus 0.3. And then the sinotubular junction, there are measures for that as well, and the proximal aorta. So you need to have an idea of these measurements. So what are the recommendations for looking at the aortic root? So the aortic annulus should be measured at mid-systole. And I can see you might get something like this on your test. Again, the annulus should be measured mid-systole from inner edge to the inner edge. All the other aortic measures are done in end diastole. So all other aortic root measurements, that's the maximum diameter of the sinus of valsalva, the sinotubular junction, and the proximal ascending aorta should be made at end diastole. Okay, so not only you'll probably get this in the test, but when you're doing your studies, you should follow the guidelines. Okay, and of course, in a strictly perpendicular plane to that of the long axis of the aorta. And I'll show you again it should be perpendicular to the long axis of the aorta. So this is the long axis of the aorta, okay? So your measurements should be perpendicular to the long axis. And those are the 4 sites again, okay? So again, the annulus is from inner edge to inner edge, but all the other measures is from leading edge to leading edge, okay? And the reason why these measurements are so important today is because of the procedures that we do, the TAVI and the TAVR. What about the inferior vena cava? Now, we have to look at the inferior vena cava because that's how you're going to get your right ventricular systolic pressure and your pulmonary artery systolic pressure. So we examine the inferior vena cava from the subcostal view, and it should be a part of your routine examination. So when you're measuring the diameter of the IVC, it should be measured in the subcostal view with the patient in the supine position, patient lying on their back, and you're going to measure about 1 to 2 centimeters from the junction with the right atrium, so just a little bit inside the inferior vena cava, using the long axis view, okay? Again, the measurement should be perpendicular to the IVC long axis. The diameter of the IVC and the percentage decrease in the diameter during inspiration, that correlates with the right atrial pressure. So the size of the IVC and how much it collapses with inspiration is a measure of the right atrial pressure. So when we talk about the collapsibility of the IVC, we're talking about what type of pressure is the IVC seen from the right atrium. We say collapsibility with inspiration, but you often have to do a brief sniff to elicit that response, because normal inspiration may not elicit this response. So don't just look and do your measurements. You can ask the patient to do a brief sniff that they're going to inspire to see how much collapse you're going to get in the IVC. So for simplicity and for reporting purposes, we're going to simplify the whole thing. So if the IVC is less than 2.1 centimeter and it collapses more than 50% with inspiration or with a sniff, it suggests that the right atrial pressure is normal, and you give it a value of 3. The range, however, is 0 to 5. Then the other extreme, if the IVC is greater than 2.1 centimeter and it collapses more than 50% with the sniff or inspiration, then you have a high right atrial pressure of about 15 millimeters mercury, and ranges from about 10 to 20. But you can just put the absolute number. Don't put the range. The person who is reading it knows that there's a range. So normal, less than 2.1, more than 50% collapse with sniff. And then abnormal, greater than 2.1 and less than 50% collapse with sniff. And anything that comes in between, then we give it a value of 8 millimeters mercury. So remember, that's right atrial pressure, and the range is from 5 to 10. So this is a part of your routine study as well, because you should report our right ventricular systolic pressure or pulmonary artery systolic pressure in all your patients if they have TR, tricuspid regurgitation. So this essentially concludes chamber quantification. You guys need to read the AC well, it's the same thing, but read the manuscript, read it, and this is what you should be doing when you doing your studies. Not only that, but this is what you're going to be tested on. This is what you're going to be tested on. Just the guidelines. So you should know the guidelines. All right. So um, the next series of lectures, we're going to look at guidelines again. And I am not sure. We'll probably look at regurgitation. Not 100% sure, but we look at regurgitation. So strictly guidelines again. And sorry about the lateness of today. All right? Okay. Bye bye.